I should say thank you. I think you guys have been on board for a while now, but I always stress thank you for being part of the VELscope family. Our goal this year is to increase awareness, and we're really beginning the process of trying to figure out how can we reduce oral cancer by 20% in 5 years, which is a pretty lofty number. And the only way is we can't do it. You really have to play a critical role in that process, you and your teams, in order to facilitate identifying things early. So the only way we can prevent cancer from occurring is to catch it before it becomes cancer. And hopefully that's where VELscope really becomes a critical part of that process. So I always stress this is not about oral cancer. People link us with the oral cancer screening device and so forth. But at the end of the day, it's about screening patients regularly so that we find lesions early. And if we find lesions early, we prevent these patients from ever being diagnosed with oral cancer. Just as a reminder to share, because unfortunately these numbers change every year. But when we look at oral cancer, looking at the mid-70s to the early 2000s, you can see there was relatively the same amount of numbers, nothing dramatic in terms of increases. And this is when patients smoke more regularly, right? And it's sort of interesting because actually as smoking declined, we see the numbers going up significantly. And if you look at that slope, that number represents almost a 50% increase in the last 10 years. And if I told you breast cancer increased 50%, I guarantee people would be testing the air and the water, what the heck's going on. But these numbers are going up. And so if we want the numbers to go down, we really have to increase awareness. And the only way we can increase awareness is to screen everyone, share what we're doing, and hopefully at the end of the day, make sure that every patient that's in the chair gets a VELscope exam. So one of the things I would ask you to think about as we have this conversation with your patients, and maybe for that patient that's a little more resistant, if you will, is ask them, Mr. Smith, what do you think are some of the top 10 to 15 cancers? And usually, you'll hear colon cancer, breast cancer, lung cancer, skin cancer, prostate. Women will generally say cervical cancer, but no one will ever say oral cancer. And so that's where awareness comes into play, right? Because I feel pretty confident most men are not going to decline a PSA for prostate cancer because we know this is a standard process to identify early changes. And that's where through constant reminders, as constant offering, patients will expect to get an oral cancer exam. So putting to comparative purposes, again, most women will put cervical cancer. And at the end of the day, there's actually almost 4 times as many oral cancers as cervical cancer. So what does that mean? That means that, when we look at a form of cancer that is actually in the mid-20s in terms of its ranking, it really tells you how effective screening is. At one time, cervical cancer was a leading cause of death among women, and now again, it's in the 20th. So we know that if we can screen patients regularly, we have the ability to reduce these numbers. And cervical cancer is a great example for us to follow when it comes to implementing a process of identification early, and therefore reducing not only patients obviously of diagnosis, but obviously the deaths associated with it. So, when we look at that graph, right? So again, we saw these numbers going up, 50%, smoking going down. Doesn't really make sense, but it does if we understand this link between HPV now and oral cancer. The same virus that causes cervical cancer obviously is now a leading cause of oral cancer. Most of us in the dental community understand this, but I guarantee you 9 out of 10 of your patients have no clue about the links between HPV and oral cancer. So every female in your practice should be getting a VELscope exam at a minimum, because Mrs. Smith, why do we have a pap smear every year? It's to detect changes associated with HPV. Women are very familiar with HPV and cervical cancer links. What they're not familiar with is oral cancer. Oral cancer now is a viral disease. 70+% of all oral cancers linked to HPV, which means everyone's at risk. This virus can be transmitted just through open mouth kissing. So some of the initial studies were it was about oral sex and Michael Douglas. hey, if you are a average American that interacts in a regular fashion with other individuals, there's a possibility of transferring that virus just through oral interaction. Why this is important, we don't have to get into how many partners someone has or what do they do with their partners. Literally, if you are a normal human being in our society, you are at risk for acquiring this disease. So this is something that we're going to start talking about more in some of the direct-to-consumer programs that we're looking to launch in the near future. And that specifically is associated with the fact that studies have shown that women that have abnormal PAPs actually have a higher risk to get oral cancer now, and which is sort of scary. And again, it correlates with this increase that we're seeing. So, in my dialogue with friends and family, it's, abnormal PAPs are not uncommon. And so again, something why we really want to stress the importance of a thorough oral health examination. And obviously, if women are infected, it's more than likely that their partners are infected as well. So who are we going to screen? We're going to screen everyone basically in your practice that you deem as being an adult. Obviously, no brainer, your smokers, your patients age of over 40, whoever drinks alcohol more than 1 to a day, your vapors, which is something that we probably should add in here, who doesn't have a poor diet nowadays. And so when we add into that HPV, this basically represents 95% of your practice. So key is we want to make sure we're going to offer this to every single patient in your practice that you deem as being an adult. Doesn't mean everyone's going to accept, but we need to be consistent in that offering, both from a standard of care perspective, but then also from a legal perspective. We don't want to pick and choose who gets this, because it's going to be that 25-year-old healthy individual you never heard of before, never would have thought, never smoked a day in their life that gets oral cancer, and you didn't offer them a VELscope exam, and that's the one patient that you end up being legally liable for. So again, any patient you deem as being adult, 16 or 18 and above, if in conversations with hygiene and the doctor, you determine that maybe a patient's a higher risk profile because they've been diagnosed with HPV or a smoker and so forth, so it's okay to screen them more frequently, and you just have to determine how you want to sort of charge for that, if it's a one-time fee once a year, or if you want to charge them per exam. So of all the slides, this is probably one of the most important ones, and that is this process of assessment. It's very important to understand VELscope is not a diagnostic tool. It is an assessment tool. It is an adjunctive tool to use in your assessment process, just like a patient history form is, just like Q&A with the patient is a tool to assist in getting information, right? That's all we're doing, gathering information. So, it's the annual visit, we're updating their health form. Maybe you notice they're taking some medications that could affect their, saliva production, for instance. Now, before we start, Mr. Smith, anything new or different that you're aware of in your mouth, lumps and bumps that we should be aware of, sores and what have you? Yeah, maybe, I've got this little thing on my palate. Okay, we'll look at that. We're going to do an extra oral exam, very important, because oral pharyngeal cancer, there are lesions that obviously are below where we can see intraorally. So if we can palpate and identify those changes, that's very beneficial. We then do a white light intraoral examination. As we see things, you may want to ask the patient, Ms. Smith, I see something on your cheek. It looks like you're probably biting your cheeks. Is that correct? Yeah. I see something over here. Have you noticed it before? What's going on? I don't really know. So it gives us a little more direction so that when we do our VELscope exam, we have somewhere to focus on. So we now pull our VELscope on. We're going to follow the same protocols of our white light exam, whether that's, left over right, vestibule, and what have you, forward in the mouth, back of the throat, lateral borders of the tongue, and so forth. You want to confirm, oh yeah, I can see with where you're biting your cheeks, confirming it's just irritation. Might want to consider a night guard, which we can talk about further about that. Hey, I noticed something here, sort of the right tonsillar area. Do you know if anything, maybe you jabbed yourself or ate something that caused some trauma back there? Not really sure. Okay, well, we're going to continue to evaluate. Maybe we'll have you come back in a couple of weeks. So point is, you're garnering all this information, feedback from the patient, what you see under white light, palpation intraorally and extraorally, to determine what our next steps are if we see something of concern that warrants potentially both a revisit and or a referral. But if you garnish all this information, you should feel much more confident regarding what the next steps are going to be for that patient, and therefore have a high level of confidence that this warrants a potential referral. But all this is going to make it a lot easier for you to assess. So 30+% of your patients have some form of abnormality, right? Whether it's a fibroma, cheek biting, what have you. Obviously, you're not referring 30% of your patients to a specialist because you have a pretty good idea of what it is. And most of them are very common. But it's always important to understand from a white light perspective, because VELscope is part of your white light examination. If something does not look normal, you're not sure what it is, even if we confirm with VELscope that it's benign, you definitely want to make sure you have a sense of what the diagnosis is in order to achieve appropriate treatment protocols. And that may mean sending pictures to a specialist or a referral to a specialist, but we stress it's always important to have a diagnosis. So when we look at VELscope, or excuse me, when we look at oral cancer, unfortunately, and we talk about that 54,000 plus number that were end of 2021, the problem is most of those oral cancers are found at a late stage, stage 2 and greater. So what does that mean? That means our survival rate is about 50%, which has pretty much been the same survival rate for the last 30 years. So even though we're more attuned to screening, even though at least within the dental community, we're more aware of obviously the importance of screening and the causes of oral cancer, we're not finding it any earlier. And the reason being is that when we are finding those changes, they tend to be, again, late stages when they're at the surface, when we can see them. Before mammograms were available, you would do manual palpation of the breast. And when you felt the lump, unfortunately, in most instances, that lump was already breast cancer. Mammograms come into play. Now we find those changes much earlier and avoid those potential changes. That's what we're trying to do with VELscope without the radiation, without the discomfort, is find those changes below the surface where we can't see with the naked eye, and we can find them in a precancerous state. Obviously, we can remove that lesion and avoid it from progressing to oral cancer. That's how we avoid cancer, is finding in a precancerous state. And hopefully that's where VELscope really assists you. So you present this to the patient says no, right? And our first inclination is it's about price, right? We think that they're concerned that they just don't want to pay the fee that we're offering. It's really important that we ask why. Mrs. Smith, can you help me understand a little bit more why you don't want to move forward? Because this is something we believe is really important to have. And you'll be surprised that it isn't always about price. Sometimes it's like, well, didn't we just do radiographs on me? I really don't want any more radiation, or my gums are already a little sore. I just don't want any more discomfort. And so what they're saying is, I'm concerned, I'm afraid to some degree. So great thing is we can share them. Mrs. Smith, this is a safe blue light. There's no radiation. There's nothing that cause damage to cells. There's no pain. It's completely painless. All you're going to feel is a little warmth, and you hear a little fan, but that's it. So from your patient perspective, I always recommend, as you're introducing this, use the word safe, painless, no radiation, quick, just to help reaffirm that there's nothing to be afraid of. For your information, what we're doing is we're actually shining this light. That light penetrates through the epithelium, and when that specifically basement membrane that we're identifying, specifically the collagen in the basement membrane, is nice and healthy because it's nice and cross-linked fibers. It absorbs that blue light, and when that collagen is normal and healthy, it actually gives off a response. That response is called fluorescence. You can't see it through the naked eye, but the filters in the handpiece capture that response. And when it's green, it tells us that everything's okay, everything's normal. What happens though when we have dysplasia or cancer, the links start to break down. And once those fibers start to break down, because the dysplasia wants to grow, right? And the first thing it starts to do is break down the surrounding tissue. It can't respond anymore. So instead of seeing green, we see dark or black. That's it. Doesn't mean we have cancer. Doesn't mean we have 2 weeks to live. It just means there's an abnormality here that we need to investigate further. So these are all the things that are involved with providing feedback. So it's pretty amazing, like when you really get into all the clinical data, the fact that we actually identified metabolic rates in the cells. We identify changes in proteins that are indicative of potential dysplasia or cancer, besides the collagen that I referenced. So besides precancer, cancer that will show up dark, two other things that will absorb this wavelength: melanin and then hemoglobin. Melanin, African Americans, Asians tend to have more melanin in their tissue, so we have to understand what melanin looks like under white light, and then hemoglobin, which is in blood, which is a great tool for us because it's going to actually help us in differentiating between trauma inflammation versus something that we need to investigate further. So 98% of the time, all you're going to see is healthy green tissue. So if you notice here, the vascularity, that's the hemoglobin that I referenced. So you're going to see vascularity quite frequently, but again, normal healthy green. But if I put VELscope in your hand and said black is bad, didn't even tell you why to say black is bad, and then you see something like this on the right, you may be concerned. But again, VELscope is part of your assessment process. So one of the things that we know is cancer doesn't grow bilaterally, right? So one of the most common things, especially now that we're in the winter months where we have more colds, is sore throats, if you will. And from that, you should be seeing it on both sides, which reduces our concern. And we have some other steps to assess if that area is of concern or not. But the reality is, again, all the things you've learned in terms of assessing unilateral versus bilateral, irregular shape, persists for 2 weeks, upon palpation, right? If it feels soft or firm, all these things are still going to be a critical part of our assessment process with and without the VELscope. So here, we notice some black dots on the tongue. Again, if you had no clue, you might think, oh my God, this is bad. But again, our understanding of how cancer presents itself, we know cancer doesn't grow randomly. It doesn't grow in polka dots. It doesn't grow in little shape. Again, it's going to be isolated, unilateral, regular. So actually what we're seeing is increased blood flow, again, increased hemoglobin to those taste buds. And some patients this will be more prevalent than others. Here, if you notice, a dark mass. This says concern. Mr. Smith, I noticed something in your back of your throat. Do you have allergies, postnasal drip, something that's causing irritation back there? And the patient's like, I'm not really sure. Now, you initially may be really concerned, but if you start looking, you can start seeing a lot of little black polyps. And obviously, if I opened up the back of the throat, it would be too obvious. But once we see multiple areas of abnormality, that reduces our concern, right? If there was this just by itself, we would definitely be more concerned. But the fact that it's not, it's multiple areas, but not sure. Mr. Smith, why don't you come back in a couple of weeks? Let's check you out. Comes back, still there. Mr. Smith, not sure what it is. I'm going to refer you to an ENT to get checked out. Long story short, wasn't resolving. ENT immediately takes a biopsy because it's like, I don't know what it is. The only way through standard protocols is to biopsy, and it comes back as inflamed lymph node tissue, which is fantastic. That means, you know what, we don't have to, this patient is going to die of cancer, but there's something going on that needs to identify these changes. Long story short, patient ends up being tested and was identified with severe acid reflux and didn't even know it. One of the fastest growing cancers in the US today is esophageal cancer associated with acid reflux. You will see this. And this is actually more prominent where you just have these little polyps right in the back of the throat. First question you should ask is about either acid reflux, real bad postnasal drip, sometimes will cause an irritation. And if they're not sure, have them talk to their physician if they should be taking the medication. Maybe it's not working, but it's definitely warrants having that conversation with the patient about maybe seeing a physician about treating that. One of the things you're going to see very frequently is orange or red, especially on the dorsal surface tongue. It has nothing to do with cancer. It's just a bacterial response, but it's great for hygiene to maybe talk about how we need to brush or scrape our tongue more effectively, or how using a mechanical toothbrush can help get that waste, actually what it is, bacterial waste off the tongue. And we'll talk a little more about that. So white or light green in color is generally indicative of a benign state, hyperkeratosis. What we stress, though, is just because it's white or light green in color doesn't mean we ignore it just because it's not black. What's causing it? What's causing that keratinized tissue? So are there some sharp edges? Here the patient's tongue was getting caught between their teeth, which now you can address, or the doctor can address, by simply removing it and hopefully reducing that irritation, if you will, the patient was experiencing. So I mentioned pigmentation absorbs this wavelength. So again, African Americans, Asians tend to have more pigmentation in their gums. So one of the things that you want to definitely consider is making sure that it looks from what we see under white light, pretty much identical to what we see under VELscope. Here, same thing, amalgam tattoo, so that's going to be pretty much identical. But let's just say we see something dark under VELscope, right? And maybe it's not very apparent under white light. It could be or couldn't be. It doesn't matter. We're going to follow the same protocols. How do we really know if that dark spot is trauma or inflammation versus something that we're really concerned about being potentially precancerous or cancerous? One of the techniques that is, I say, godsend, it's really a benefit to helping you better determine what the next steps are, is to take your Explorer when you see something under the VELscope and gently rubbing across it. And when you see as you see the Explorer as a hygienicist rubbing across it, you can see how it turns green. So what we're doing is we're moving the blood out of the epithelium and seeing a nice, healthy basal membrane. So Brent, the basal membrane, the collagen in the basal membrane absorbs that blue light. So as we move that blood that's absorbing that blue light, and we get exposed to the basal membrane, that basal membrane now is releasing and responding. So in this case, this is a sore, specifically a denture sore. If it stayed dark when we rub across it, that definitely increases our concern that this is something we want to probably have the patient come back again after 2 weeks, and then potentially refer. So a great technique for you to manage what could be the level of concern that this particular lesion is placed at. So if we don't have a basal membrane, there's nothing to rub across, right? There's nothing to absorb that wavelength. So ulcerations, fresh wounds, bites, and what have you, where there's no basal membrane to see, is going to be dark every time. So just follow your normal clinical protocols and assessment to determine what the next steps are going to be. So, again, can't hurt to have the patient come back in 2 weeks just to make sure, especially if it's some type of wound, if you will. But as we know, with ulcerations, that could be a leading indicator of something of concern that would warrant a potential referral. Not uncommon to have some irritation on the lateral borders of the tongue here, if you notice. Not really as prominent here, but what do we know? We know that cancer doesn't present itself in a linear fashion. These tend to be bilateral, and when we rub across it, it tends to turn green. So we know this is irritation, but we just don't want to move on. What's causing the irritation? And use this as an opportunity to treatment plan with the patient. So my recommendation, take a picture of it, show the patient, Ms. Smith, you see this dark? Dark is not good. Dark is irritation. And we know irritation can lead to changes that we really want to avoid. We've been talking about getting a crown on this tooth now for the last 3 years. This could be one of the sources of irritation. Let's get you scheduled to get this taken care of. Or, one of the things, Ms. Smith, is you have sort of a small bite, your tongue's not sort of fitting. Let's talk to you about getting you into an Invisalign that will open up your bite and maybe reduce that irritation. So think about creative ways to use this as a tool to educate your patients in terms of some of the treatment options that you have that actually is going to improve their overall health. Perfect example here, because the most common thing you're going to see with VELscope is irritation associated with cheek biting or cheek sucking. 98% of the time, these will blanch. But if this patient is, they're just biting on their cheek all day long, it may not blanch. It's like a hematoma. And so definitely warrants getting this patient in a night guard. Again, take a picture, show the patient, Ms. Smith, you see this dark? Dark is not good. You're biting on your cheeks. Obviously, from a habit perspective, we want to reduce that, but sometimes it's hard to do that. So let's get you into a night guard that hopefully will reduce it. And I guarantee you, if you're screening patients regularly, this is the most common thing you're going to see, which therefore you should automatically see an increase in recommendations in terms of appliances to reduce that irritation caused by cheek biting or cheek sucking. Important to understand that VELscope is not your determining factor in terms of what to do next with a patient. And I say that because here we see a lesion that doesn't look normal, right? Under VELscope, it's not normal, but when we rub across it, it turns green. So, hey, it's blanching, it probably isn't cancerous, let's move on. No, if you're not sure what this lesion is clinically, it is imperative that you always refer out for a biopsy, or excuse me, not for a biopsy, but for a diagnosis, whatever that might entail. That could be a biopsy or not. Point being is, if we can't have a diagnosis, how do we appropriately treat it? So just because something blanches doesn't mean we ignore it. It means this still is not normal looking. And in this case, obviously, it was diagnosed as erosive lichen planus, which means it has a high probability of potentially progressing to dysplasia. So this is a clip of a lesion that is not blanching. Now, this is the lateral border of the tongue, left lateral border of the tongue. This is the anterior, this is posterior. And if you notice, something's a little off here with this picture, right? I hope you may have noticed that. And the reason being is, before they even pulled out the VELscope, they did their assessment, right, verbally with the patient, Q&A, and then a white light exam. Ms. Smith, I noticed something on your tongue, some dark maroon areas. Do you know what's going on here? She's like, oh yeah, I bit the hell out of my tongue last night, which makes sense, right? So when you see this presentation, it correlates with probably the bite. There's another little lesion though adjacent to that, and the hygienist like, Ms. Smith, I see where the bite marks are, where you bit your tongue. I see another little area adjacent to it. I'm not sure if that was part of your bite. Do you know if that little area was there before you bit your tongue and the patient wasn't sure, and that's why they're trying to blanch it? It's not blanching. So they had the patient come back in 2 weeks and it resolved. So this is an ecchymosis or a hematoma, if you will, that was caused by that trauma. And usually when you have the type of trauma, patients remember it. But to be safe, we had the patient come back in just to be sure. So I will tell you though, if this was a dysplastic lesion, just this by itself, and it's not blanching, this definitely warrants a referral if it comes back up to the second visit and it still continues not to blanch. And the reason why I really love this little video clip, because again, it's not what we see, it's this whole process of assessment, Q&A, feedback with the patient, and following protocols like blanching, and have the patient come back in 2 weeks to make sure, you know, everything is normal or abnormal that may eventually require a referral. So again, we have to know what we're blanching. So amalgam tattoos, pigmented tissue are not going to blanch. So just be cognizant of sort of what we're observing under white light. When we do that blanching technique, make sure we blanch the entire lesion. We want to go up and down, left and right. If we just go down the middle or down one side, we may miss an area like here, where if you just blanch the left side, you would have thought it was okay, but the right side was actually dysplastic. So again, we want to see that entire lesion turn green. So sometimes this used to be a question we would get a lot when we first brought this up. Here we tend to get this more from oral surgeons, in all fairness to them, because I think when people first got VELscope, or clinicians first, they were referring everything without understanding how to assess appropriately. But first and foremost, this is not a diagnostic tool. Therefore, there aren't false positives, right? All we're doing is giving you a tool to assess, just like looking under white light, just like using loops, right? You see better with loops. At the end of the day, what we're doing is hopefully following protocols that will increase something of being concerned or not. That's all we're trying to do. Is this of concern or not? Is this something of concern that eventually warrants a referral? So it's unilateral, it's a regular shape. It blanches, right? Or does not blanch upon 2-week follow-up. It still doesn't blanch. It hasn't changed shape or size, which is where the picture taking is so important. At that point, that says, I don't know what it is, not sure what could be causing it. We need a second opinion, and then it warrants a referral. And I can tell you pretty consistently, not everything's going to be cancer or dysplasia, but there is something that warrants, that has a diagnosis associated with it, that then warrants either treatment or at least understanding of what's going on. So we looked at lesions that were abnormal that weren't necessarily cancerous, right? Here we see a little white squiggly line. I don't know if this is in the trigon area. I'm not sure if this is something that you'd be overly concerned with visually, but definitely under VELscope, we're concerned. Again, unilateral, irregular shape. We rub across it, doesn't turn green. Mr. Smith, I see something, back where your wisdom tooth used to be. Do you remember jabbing yourself with some type of utensil or something that may have caused some trauma? Patient's like, I don't think so. You know what, let's have you come back in a couple of weeks just to make sure. Patient comes back. Again, comparing the picture from the first visit to the second, hasn't changed shape or size, still does not blanch. Mr. Smith, we're going to refer you to a specialist to get it checked out. Here's an area that I'm a little concerned with, but we refer you to a specialist. At which point it was determined biopsy was warranted, and it comes back as CIS, which is fantastic. So with that, no problem. Thank you so much for participating. So at this point, we refer to comes back. So CIS is awesome, right? So we caught it before it becomes full squamous cell carcinoma, which means we avoid the radiation, the chemotherapy, and we're not losing half our jaw. So again, this is our goal, right? We want to find it before it becomes full-blown cancer. So this patient was referred for the polyp, and thank God they had the polyp was ordered for the polyp to be identified on the dysplasia and the CIS located adjacent to it. If you notice, the polyp is actually green, which tells us it was benign. So, these leukoplakias we see all the time, and we tend to observe them because most of the time they're benign. The problem is you see one lesion, it's benign, right? You refer out actually to an oral surgeon, it's benign, and you see like another patient with almost identical lesion, it's like, it's the same thing, you don't refer, and that's the one that ends up being dysplastic. So point is, we don't want you to have to pick and choose who you refer or guess or assume. Follow the protocols, and you're going to feel so much more comfortable in regards to how you're assessing. So these lesions were in observation mode for over 2 years. This one we're not observing anymore. Again, unilateral, irregular shape, does not blanch, persists for 2 weeks. That says, I don't know. Let's get a second opinion. Upon biopsy, it's biopsy to severe dysplasia, which is awesome. Again, we caught it in a precancerous state, which means we're not losing half our tongue, and we don't have to go the process of surgery and so forth. Or well, we're gonna have to have it removed, but don't have to go through the process of chemotherapy and so forth. The great thing is most of these lesions you see actually will be benign. So hyperkeratosis, linealba lichen planus will be light green or green in color, which tells us it's not cancerous. But I stress, doesn't mean we ignore it. So VELscope says, hey, it's benign. But what's causing it? Why is it here? Is it a sharp cusp? Is it an allergy? Is the patient biting on their tongue in some way? Point is, if it's not resolving in 6 months, 12 months, whatever the doctor's comfortable with, please refer. Just refer just to confirm this is hyperplastic, or send a picture at least just to confirm what it could be, understanding that VELscope showing us this benign. Just standard protocol. Even if we have a sense that it's benign, we never want to assume. We always want to have something that's more definitive because, again, VELscope is not diagnostic. This patient was sent to NYU's oral medicine department for an hemangioma in the lip, and when the NYU practitioner brought his VELscope, you can see the lesion on the floor of the mouth. And his response is, yeah, probably the doctor was so focused on the lip, didn't really notice a slightly raised area of the floor of the mouth. And this is why I really believe VELscope is so beneficial for us, because it's these cancerous lesions are so hard to see. This was diagnosed as stage 1 squamous cell carcinoma. So this is already a cancer and you barely see it. If you miss this, you are not missing this. VELscope increases your sensitivity of almost 60% when you compare it to a white light examination. And therefore, if we point this in the direction of the oral cavity and look through it and there's something abnormal there, there is an extremely high probability that we will identify it as opposed to miss it. And one thing I would stress too is, let's say the patient says, no, I don't want a VELscope exam, but you see this, Mr. Smith, I care about you so much. We're going to do this exam anyway, because I just want to make sure everything's okay. This, by the way, is a stage 1 squamous cell. So it, again, reinforces how insidious this viral caused disease is. So this is our goal, folks, not to find cancer, find dysplasia. And this is a perfect example of finding a precancerous lesion that isn't readily apparent under white light, that is now something that we can identify, treat, and again, monitor from now on to hopefully avoid from becoming cancerous. So, I just want to stress that as clinicians, a lot of times we are behind in terms of our time with the patient. A lot of things occur out of the blue that take more time than we're expecting to have with the patients. But I would stress that it's imperative that we do a thorough oral health examination, but at the same time, it's still challenging to find these changes under a normal white light process, because here there is a cancerous lesion that is barely noticeable under white light that's readily apparent under VELscope. Unilateral, irregular shape, persists for 2 weeks, does not blanch. That says referral, and this is identified as a mucoepidermal carcinoma. So this is a carcinoma that many people do not identify under white light. That is obviously easily identified under VELscope. So one of the biggest challenges we have when we first came out with this technology is you see something under VELscope, you refer to a specialist who doesn't have a VELscope. It's like, I don't really see anything. I don't feel comfortable taking a biopsy. And you're like, well, what do we do? How do we communicate? There's something there that we want to investigate further. And so the way that we were able to reinforce the urgency was to facilitate a process of photo documentation. So now, hopefully, as you've received your VELscope with the iPod Touch, which you attach to the back, what I would recommend is put this back and leave it on, so then you can just attach your iPod Touch to it anytime you see something suspicious. But now through the app, take those pictures. It downloads images, or excuse me, you can download the images to the patient chart. You can email them if you have Wi-Fi in your practice to outside, but now gives you the ability to both monitor and manage those patients and compare from one visit to the next. But then secondly, gives you the ability to communicate outside of the office in regards to what's going on and where to focus on potentially for further investigation, or a critical aspect. So I would highly recommend, please get used to using this. As with anything, if you don't use it regularly, you don't use it at all. And so as you use it more regularly, and the reality is most things you see are not going to be cancer oriented, but you can use this so effectively to communicate treatment plan with patients and help them really see a technology that then warrants a fee that you're charging. And I think that as well helps to reinforce that. So one of the things that why the camera is so beneficial, I believe you guys offer Oral-B or Sonicare, I don't know which one, but that porphyrin response that we talked about is something you're going to see very frequently. Take a picture, show the patient, Mrs. Smith, you see this red, this is called porphyrin, or in layman's terms, bacteria poop. And the problem is with your manual toothbrush, it's just really hard to get it off your tongue. That's one of the reasons why we would highly recommend our Oral-B and Sonicare, because the mechanical toothbrushes allow you to not only get that gunk off the tongue or the waste off the tongue, but just like it's on your tongue, it's in your gums. And so these devices help us do a much more effective job of cleaning your mouth, cleaning your gums and your tongue, that again, your manual toothbrush isn't doing. So again, using this as a great tool to communicate and reinforce some of the things that you recommend can be really beneficial. So for your information, and every now and then you're going to have someone in the medical profession or an engineer is like, I've never heard about this, is this a gimmick? Your immediate response could be Dr. Smith, Nurse Smith, Engineer Jones. The only reason why you're offering this is because there's so much clinical data to support this efficacy. There's actually, we would feel that we're not offering something we should be because of how proven this technology is. And for your information, so you can go to our website. There's tons of all these studies that are listed that really, prove the efficacy of the technology. So reimbursement, there's a code for reimbursement, D0431. You guys actually have maybe a little bit higher reimbursement, I guess, than others, maybe about 25%. But at the end of the day, unfortunately, the Deltas of the world never will cover for this. Every penny that they're saving, or every penny life, if you will, this probably represents like one penny per patient life, but it's a penny out of the CEO's profit. So, but more and more the medical dental plans like United, Humana, Guardian are covering for it because it actually saves them money on the back end for treating patients with oral cancer. But what we find, it's not about it's not about the charge per se as much as it is value. So if you just introduce this, hey, Ms. Smith, this is a technology your insurance isn't going to cover, and it's XY dollars, you're going to find most patients are going to say no. If you provide information that helps understand how important this is, that HPV is now a key indicator for oral cancer, the fact that it's painless, it's fast, you're going to find more patients readily accepting the technology. So as a recommendation, I stole this from a practice that got significant reimbursement or significant acceptance, and from patients in terms of paying out of pocket, actually. And that was, they actually introduced this when the patient first checked in. So there's VELscope brochures, there's laminations that you can develop that we provide examples of. And they were giving this patient when the patient checked in, and basically saying, Ms. Smith, this is, something that we're now offering, something that the doctor wants every patient to have. Take a second to read. If you have any questions, you can ask the doctor hygienist when you go back. So instead of looking at their phones or reading People magazine, they're reading about all the benefits associated with technology. They're reading about HPV being a leading cause. For some people, understanding maybe personal perspectives, but some people like to say, I've seen in Dr. Oz and the doctor who provides credibility. So now they're getting value, right? Now they go back. Number one, not only are they getting value, many of their questions are being answered. So it's going to save us time from when they go back. Now they come back to simply say, Mrs. Smith, hopefully you read the information that we provided. This is completely safe. It's painless. It's fast, but it just gives the ability to see things we can't see with our naked eye. Shall we move forward? And at that point, what you'll find is a lot of patients will either say yes, or they'll say, well, how much does it cost as insurance cover, right? And so the thing in your area, Delta Dental has this at a fee schedule of $65, which they rarely reimburse, but it's set in their fee schedule. So you can say, Ms. Smith, the normal cost of is $65, but you know what? The great thing with insurance, most you're going to pay out of pocket is whatever you're charging. And so number one, it provides a sense you are providing a discount. But then secondly, if it's covered, it's covered. If it isn't. But this is what your out of pocket is going to be. If you say this isn't going to get covered by insurance, and I'm telling you, you just never know. You will have a Delta plan that's pipe fitter 101 that will cover it. But I saw this from practice at 90+% acceptance, and I just thought it was really effective in terms of the way they were communicating. So one recommendation, I will be providing you some verbiage, examples that everyone in the office can use that hopefully meets everyone's level of comfort. So if we find something suspicious, obviously you're going to refer like you normally do as a specialist. Oops, I'm skipping so from a time perspective, but lastly, the exam itself. Again, the goggles are for the patient. This is not like a curing light, so you don't have to be concerned about damage to your eyes, but it is a bright light. So obviously it's just for patient comfort. We want to be about 2 to 3 inches from the oral cavity. Again, please put your plastic sheath and your paper cap that's meant to be used per patient. Your distance is going to, again, 2 to 3 inches from the oral cavity. It's okay to touch the mouth. That's why we have the paper cap on here. Whatever you're comfortable with in terms of distance from the end of the handpiece. Although you see on the picture the clinician has against his eye, I think most people end up being about 4 to 6 inches away. And again, we want to be 2 to 3 inches or closer to the oral cavity. If you wear loops during your white light examination, I recommend continue wearing your loops. Establish your distance first with your loops on, and then bring the VELscope in. So you're going to maintain your normal distance from the patient, and VELscope's just going to be in between you. One of the things that I think hopefully will assist in making sure that you identify as clearly as possible, if you can turn off the lights in the room, and you'll have greater contrast. Now, this was meant to be used with a fairly lit operatory, so if you can't turn off, that's okay. What I find is probably the most difficult is when you have an open bay window with the sun coming in. So if you can lower the blinds, I think that'll help, or at least put your body in between the light and the sunlight, if you will. The other thing is, please make sure to, again, use the disposables. The number one reason why these units get sent back is because the LEDs, which is the most expensive part of this device, goes bad. And a lot of times it goes bad because people are wiping this down with cavicide or alcohol, and it leaches back behind and kills the LEDs. Never use any liquid here in the front. Try to avoid any liquid at the base where it's in the charger. If you feel like you have to use a cavicide, just squeeze that out, cavicide wipe, squeeze it out as much as possible before wiping it down at the outside. And again, use a fresh cap in the front as much as possible. So with that, we are going to be sending this to you in the form of a recording. You'll have my contact information if you have any questions. I guess I'll open it up if there's any questions that you may have that I can answer at this time. Well, thank you again for being part of the VELscope family. Again, you're going to find some links that I'm going to be providing, which will be a video how to do a VELscope exam, some materials that you can use as well. And then lastly, yes, I'm going to give you a recording of the PowerPoint of this webinar. Will that be acceptable? Yes, okay, awesome. Thank you so much again. You'll have my contact information. If there's anything else you need, just let me know. And here's the screening. And by the way, just FYI, Oral Cancer Awareness Month is coming up in April. So we really want to make sure that we're reinforcing the opportunities to get the word out. And so just be, I guess, ready to hopefully have some things that you can start sharing with patients to help educate them on how important it is to be screened by you. And just as importantly, how they need to be sharing this with their friends and family to get them in to be screened by you as well. So with that, enjoy your VELscope and let us know if there's anything else you need. Have a great day.